Okay, perfect. So we are about to start our PMHNP coaching. So let me start the meeting.
When you give an antidepressant, hey, how are you?
Perfect. Hey,
Hello.
good to see you guys. Good to see y'all. Okay, let me start.
I'll ask you later. No worries.
What do you want, dog? The dog is trying to sabotage my spam.
The genome thing was good.
Okay, good. I'm glad you liked it. Yeah, it's the start of start of many. Got a lot more coming up. So yeah, I'm glad it was helpful.
It was informative. Yeah.
Yeah. Okay, perfect. So we're sharing. Oh. Actually, y'all can see my screen here?
Yep.
Okay, excellent.
Oh, how was Iceland?
It was good. It was good.
Yeah.
Definitely the most beautiful place I have ever been to personally. But yeah, incredible.
I've heard. Did your sister get engaged?
She did not. No, that did not happen. Yeah,
My brother got married in Iceland, so.
Really? He got married in Iceland?
Yeah, he eloped to Iceland.
Not a bad place to elope to. I can understand the appeal. But okay, let me resume the recording. Okay, excellent. So we can get started. Awesome. So, okay, I'll wait for Lavita's question because I know she'll probably come in and then I'll answer Lorraine's after. Okay, so we got Richard. Why don't we start with yours? So you mentioned about starting dose for stimulants. Yeah, so yeah, anything that led to this question? Yeah, what were your thoughts?
Yep. It's one particular patient led to this question. She came to me originally with generalized anxiety disorder as a psychologist referral, because no matter how many coping mechanisms were taught and grounding techniques, CBTA, etc., was instructed, she still was not doing too well. Anyways, long story short, I started Effexor monotherapy and she did phenomenally well at 225. Literally about 3 to 4 months passed. Her anxiety on the UD7 scale went from moderate high to very mild, almost to a zero, which was great. But as I was conducting my assessment, I realized that she was still manifesting some symptoms of ADHD, and it seemed to be the right time to have that conversation. Um, as per the scale, it seemed like she was scoring moderate to severe of the ADHD. Upon further questioning, it turns out that she has not graduated high school. She did a GED, and she said that she literally got help from some family members, and she did it online. Anyways, the ability to focus and stay still was very prevalent during her upbringing, and was still relevant on the presence of Effexor. So far, my experience is that the for methylphenidate in women is a better idea. So far, I find that they are more responsive to it than men are. But that's just my own experience. I wasn't sure about your experience. Long story short, I started her on, I think it was Focalin. I started her on it, and then she was bouncing off the walls, super stimulated. It during the one of the appointments, she grabs a paperclip and she starts hanging it on front of the camera, and I was like, "Hey, focus on me, talk to me." And I was like, "Oh, I'm sorry, I just need to be doing something at all times." And I was like, "Okay, well, we're definitely very overstimulated. Let's talk about how we can mitigate it And if you're so interested in ADHD treatment, we can find an alternative. Currently, I'm theorizing she may respond to a Cetera. I remember in one of your previous lectures, you explained that non-stimulants are maybe 30 to 50% as potent as a stimulant. So that could be a place to start. And anyways, that led me to the question. In addition to age, gender, maybe weight in adults, is there any other parameter that you look at when assessing what dose to start with?
Yeah, so good question, and thanks for that contest. So let's walk through everything that you just mentioned. So, how old is this patient?
Mm, I have to look it up, but I believe she's in her early 30s.
Early 30s. Okay, got you. So, definitely not a kid. So, that's the first thing. Peds, paradoxically, can require higher doses than adults can because their metabolism is quicker. And I
Mm.
specifically remember this because when I learned this fact, it surprised me as well. I thought that, oh yeah, peds, you would use a lower dose, adults use a higher dose. Specifically, uh, and for stimulants, oftentimes they metabolize things quicker, so they can pump through XR meds quicker, they can pump through IR meds quicker, so they may need more of a dose. Like they might start at a lower dose just to be tolerant of side
Mm.
effects, but you might find yourself titrating more in the pediatric population or going to a higher dose than you expected because they're metabolizing things quicker. Just like Lavita said here, Sue, like some of the patients, pediatric patients on max dose of stimulants and some adults on lowest or second lowest dose with therapeutic effects. So that's one of the important things to just acknowledge there. In terms of starting doses, so the lowest dose or the second lowest starting dose is usually a consideration. However, let's say the patient has had some past trials of meds. For example, I had a patient who had tried Vyvanse 60 milligrams in the past. And so in her case, she had tried lower doses and found they weren't as effective as the higher dose. So
Mm.
but we didn't want to start Vyvanse because she had some problems with it. So we decided to go with Adderall. So in Adderall, I started her at 15 milligrams and quick XR and quickly went to 20 and then 25. Reason being because I knew that she had done well or she had taken 60 milligrams of Vyvanse before. Thus, I was okay with starting it with a little bit of higher dose, knowing that okay, she was on a high dose of Vyvanse, then likely we're gonna have to go to a higher dose of Adderall. So that past trial made it more helpful. Family history can also be helpful because if the patient has a big family history of ADHD, then you can ask about the doses of what the family's taken. And if they've taken higher doses, it's likely that the patient is going to need a higher dose as well. I mean, we just had our Genomind lecture, so pharmacogenomic metabolism. If someone's a fast metabolizer, rapid metabolizer, ultra rapid metabolizer, they might need higher doses. Versus if they're a poor metabolizer, they might need lower doses. And of course, the individual pharmacodynamics of the specific genes and interactions that occur. Um, there's also severity. If the person's case is more severe, then it's more likely they need a higher dose. So you might want to start with a higher dose. Because remember that stimulants are something that give therapeutic benefit very quickly, so you can titrate relatively quickly too. Unlike something like an SSRI where you may have to prolong it. So we want to get the patient as better as quickly as possible, especially for an ADHD patient who is already a little bit more impulsive and impatient than the average patient. So that kid, if you want to get effect a little bit more quickly, and let's say the patient says that they're okay with having a little bit more side effects, especially at the beginning, you could consider starting at a higher dose and downtrending from there as well too. So that is a strategy too, especially if you want to work a little bit more quickly. There's comorbidities. So let's say if there's anxiety, bipolar, tics, cardiac issues, that can trigger you or prompt you to start at a lower dosage to avoid exacerbation of side effects there. In terms of gender, I personally haven't noticed much of a difference between guys and girls and dosages. But that's just my anecdotal experience. I'm not aware of any evidence that suggests using one or the other. However, I am aware that guidelines say that for kids, methylphenidate can be a little bit better tolerated, so consider starting that as first line. And in adults, the amphetamine class can be a little bit more effective, so consider starting that in adults. But that's just a general guideline. And and then in your patient's case, you mentioned the Strattera. I would be hesitant because they're already on venlafaxine, so you're going to get a bunch of norepinephrine activity there anyway. So I doubt that adding in Strattera is going to give much more benefit there. But overall, with stimulant titration, stimulant starting dose, really go off of patients, how well they tolerate it and how much function they improve, and then adjust your titration based off of that, rather than like preconceived notions on age, gender, weight, etc. Does that make sense? I think you're muted.
Sorry, I did mute myself.
Yeah.
You hit a lot of great key points. That's the reason why I wish to discuss it. I was definitely going into unknown waters, and so I do appreciate your insight. I have a follow-up question then.
Yeah.
If Strattera would not be the right choice because she already has Effexor, then what would you suggest to do? I think I gave her the second highest dose of that Focalin or Ritalin. Again, I don't remember which of the two. So aside from giving her the lowest, what other suggestions do you have?
Yeah, so you're saying that she's on the second highest dose of Ritalin or Focalin?
Yeah.
So remember that the FDA, and she's tolerated it well?
No, she became very hyperactive with stimulated.
Okay, so what would happen if you decrease the dose?
That's a good question. I asked her to start a washout period just so that we could go back to square one.
I see. Okay. So you could consider something in the other class. So you tried Focalin or Ritalin, right? So those are in the methylphenidate class. So you could consider something in the Adderall class. Sometimes patients tolerate one versus the other. If hyperactivity is a concern, you could consider adding in a non-stimulant like guanfacine or clonidine. That could be helpful because those non-stimulants are more calming, so that could balance out some of the hyperactivity that she's having. Propranolol could also be helpful in that case, or just tweaking the methylphenidate dose a little bit down and seeing if she still retains ADHD efficacy without losing or without with hyperactivity getting better.
Okay, so you mentioned guanfacine, clonidine. Do you mention a third one?
Guanfacine, clonidine, the Adderall, tapering down a methylphenidate.
Okay.
If there's a lot of heart rate increase, propranolol could be helpful. Like if she's just like amped up, you could use that. You could use a calming intervention like L-theanine, for example, if you want to go the supplement route, because L-theanine is used to pair with coffee to help calm down the jittery effects of coffee and caffeine. So L-theanine could be very helpful in that case too.
Got it. All righty. Yeah, great feedback. I appreciate your input.
Yeah, of course. Anything else?
Not that I can think of right now.
Okay. Got you. So, all right. So that was Richard. Okay. So, have we had Levita or Lorraine join at all? Okay, no worries. So I think Patricia, you are with us here. So I do believe I remember that you had a question. Yeah, would you mind if we went over Charles Bonnet syndrome? I understand it's considered a neurological condition. Have you been consulted for a case that turned out like this? Or when you suspect it based on the nature of the hallucinations, how to distinguish it from other stuff? Yeah, Good question. So I have never personally been consulted for Charles Bonnet syndrome. Have you? I'm just curious what prompted that question.
I was asked to see a patient that was having hallucinations, but when I went over her notes, I saw from the neurologist that she had this condition. So, and then I spoke with the my psychiatrist, and he said that antipsychotics don't work for this. So I was just wondering if you had any experience with this at all.
Yeah, good question. So I personally haven't. So basically, what Charles Bonnet syndrome is. So this is I was doing research on it. It is when a patient has hallucinations, a geriatric patient typically, they have hallucinations with visual impairment, something like macular degeneration, glaucoma, cataracts, some retinal detachment. But the key is that they're cognitively they're doing well, so their insight is intact, their cognition is intact. They don't have other stuff like delusions, paranoia, auditory hallucination. Like they're very acutely aware of what's going on. Whereas if you compare that to other psychoses like schizophrenia psychoses or bipolar manic psychoses, they're often those in those cases they don't have insight. Their reality testing is messing up. They may not be aware of what's happening. The hallucinations could be very distressing to them, and so that is the difference here. And so usually to treat it, you would want to treat the optical condition, whatever the optical condition is. So I would think that consulting ophthalmology would be the move here, as long as the patient is able to be safe and be able to walk around and get around and stuff.
Yeah, she is going to see them, I think, in the next few weeks. But they were just wondering because she was very distressed by the hallucinations. She knows she's having them, and it's just the visual hallucinations. And she doesn't have a history of dementia or confusion or anything like that. So I just was just trying to treat more so the anxiety and depression portion of it. So.
Got you. And it is important to address that as well, right? Because it causes distress. But it's key that you mention it, because we shouldn't get misled and think, oh, this is a hallucination, when it's primarily driven by the lack of concrete visual stimulus.
Right.
Yeah.
So the medical wanted me to treat it, and then I talked to the psychiatrist, and he's like, well, we really can't, so.
Yeah.
So I just tried to treat more of just her distress more so than anything else.
Exactly. No, I think you're on the right track for sure. Just reassure and make sure that she gets the treatment that she needs.
Right.
Okay. Anything else on that?
No. I was just wondering if you had any experience with that, because this is my first time.
Yeah.
Having to have a patient with that. So.
May I ask what she was hallucinating?
So she would see fish, birds, anything really, like mostly animals. She would see patterns. She would see, and almost like she was having the illusions as well, as far as like the shadows moving. And so, I mean, that was pretty much it. Not people, but just more so patterns and animals.
Yeah, when I search the hallucinations, like I just keep seeing all these animal stuff, like these dogs,
yeah, that's what she was seeing.
cats. So I guess that's a good way to tell apart too, is what is the content of the hallucinations.
Yeah, she would see like fish, just like.
There's a kind of dementia that patients often hallucinate small children or animals. Is that Pick's disease? I don't remember.
I think I've seen. I know I've heard Lewy body maybe.
I don't remember.
Yeah, I don't remember off the top of my head.
Yeah. And I know that some of the patients that I see that have Lewy bodies say they see children or animals.
Oh, interesting. Yeah.
But not really.
Yeah.
I mean, that's usually like a common theme that I've noticed when I see the Lewy body dementia patients.
Gotcha. Okay.
Yeah, Lewy bodies. You got it. I'll just
Yeah.
Google it.
Thanks for sharing that with us.
Thank you.
Yeah. Okay. Awesome. So let's go through. So Michelle says, can you share a follow-up medical management note with psychotherapy add-on, like you did for H&P? So Mileo Sawanki, yeah. So I actually just uploaded one, so I'll share that. But basically, with the psychotherapy piece, all you really have to do is just indicate something that you did for psychotherapy. Like, it could even be like a sentence or two. For me, I often just do it in my my HPI, or like the if you have a SOAP note, so in the S portion, just indicating that, okay, discussed stress in the home, stress in the marriage, worked on you supported psychotherapy, or you can do it in the assessment and plan portion of piece, like you just say, okay, psychotherapy discussed, uh, you know utilized X intervention, use CBT principles. It doesn't have to be detailed, and that way, if you're doing private billing, for example, you can do your billing codes of 99214, which is the medical management side, and then the 90833, which is a 16 to 38-minute psychotherapy add-on that you can add on to that code. So that way you can do more billing, and then you can get more reimbursement back for the visit. Does that make sense? But yeah, so over here I put under sample follow-up note. So this is under classroom, diagnostic assessment, and then sample H&P and follow-up note. And so basically, like, just like a standard thing. And so you could put it, like, for example, here in psychotherapy plan, psychotherapy, yeah, like sleep wake eating log, for example, sleep hygiene, cognitive restructuring. It doesn't need to be detailed, and in fact, it shouldn't really be detailed because it's supposed to be a private thing. Yeah, so you don't need to be documenting every single thing that the patient says. Yeah, any questions on that? Okay, perfect. So Melody says, I'm interested in any input on therapeutic communication techniques for pediatric and adolescent patients, doing clinical at crisis stabilization hospital where many are repeat admission. Thank you. Yeah, so this is a great lecture. So I actually just made another one for that here. So this one is under the same category. So this is on building rapport with kids and adolescents. So I go through it in detail, just stuff that I've learned in child and adolescent psych training and different settings too, like like school settings, emergency room, inpatient, outpatient. So there's a detailed video to watch on that. But just some basic things is you want to start the interview with asking about the patient, something that they're into. For example, when I had my in-person office, then I had video games on the side wall, games that I had like anime posters and things hung up. So that way, like, because I'm into that stuff. So then the patients who are also into that stuff would either look on that or comment, and then it was a very easy bond that we could develop. But even if they weren't into that stuff, I would ask them, like, what are you into? What kind of stuff? Do you play sports? Are you into reading? Whatever it might be. And that way, I'm establishing some level of connection. So I'll always spend a couple minutes just developing some level of rapport with the patient. If it's outpatient visit, like a first visit, might spend a little bit longer. If it's more of like a crisis visit or like, okay, we got to go, emergency room, might spend a little bit shorter, but I always made sure to prioritize that. The next thing is to don't come across as preachy, judgy, kind of from top down, but rather viewing myself as an ally to the patient. And that's super important because if you think about a kid or teen's life, they have no power. And so they're used to adults, their parents, their teachers coming from top down, be like, hey, do this, do your homework. You need to stop doing rebellious stuff, do this, do that. And so they're used to that all the time. So it's very refreshing for them to have someone who actually values them as a peer or wants to actually take into consideration their opinion, their thoughts. And so really approach it from a collaborative frame of you guys are working together to solve the problem, rather than you are the protective adult who's going to dish out instructions from above. So I think focusing on the rapport, using the good communication techniques like validation, reflective listening, curiosity, using those three things: validation, reflective listening, curiosity, and alliance building. I think that will take you really far with pediatric and adolescent patients. So, any questions on that?
What is the cool cartoon to look at nowadays?
I mean, there's so many. A lot of kids are into anime. A lot of kids are into video games. A lot of kids are into comic books, Marvel stuff. I'm sure there's new stuff that I'm not into. A lot of them are into social media, so you can always just ask them about social media, what platforms they're on. What you could ask them what YouTubers they watch, what they're on, what TikTok stars they watch, other things like that. So you can always ask about any of those. Just ask them. Every kid's into something different. Many kids are into sports. Uh, Many kids are into drama, instruments, music, whatever you can find to latch on a connection to. Like that's the most important thing.
Have you seen any kids interested in adult-oriented video games? Specific, I'm thinking about the Grand Theft Auto franchise.
Yes, yeah. So plenty of kids are into GTA for sure. So yeah, I mean, like that's usually the first visit isn't the time for for me to get into the pros and cons of them playing mature rated games, right? Like there's other things to address, but it's something that I might just keep in the back of my head. I would rather use even if they play a mature game like GTA, you just use it as something to build an alliance with.
Do you, in your own experience, believe there's any connection between uh, being rebellious and a game such as Grand Theft Auto?
Yeah, good question. So research goes back and forth on this. Most of it's saying no. I mean, that's what I'm inclined to believe. I think that a lot of people who have rebellious tendencies and things, they can use GTA and other games to express those rather than expressing them in the real world. However, if they do it too much, then that can become a coping strategy for these kids and adolescents rather than solving their problems in real life where they just go retreat to the game. So it's a very tricky balance, but I don't believe that the games are causing like aggression and things. I think there's probably other things, and the games are rather a coping mechanism to help with that.
That's a great thought. Then we should educate the politicians that blame violence on video games.
Yeah, of course, but that's a whole separate topic. I think they just need a scapegoat for uh, to sell the public on something. But I actually had a talk I gave, so it's on gaming addiction for parents and mental health. So I uploaded that in the diagnostic assessment category. So if this topic interests you, definitely check that out too.
Appreciate it.
Yeah. Okay, anything else on this topic, the therapeutic communication for peds and adolescent patients? Okay. So Melody also says that she has a case. So this is a 29-year-old single male. He's got substance-induced depressive and persistent depressive, diagnosed with ADHD, tried stimulants. So as an adolescent, tried stimulants, didn't like. Now uses the greens here, illicit stuff 3 to 4 times a year. Okay, knows he needs to stop his tries twice, has not been successful. Okay, so passive SI here. Irritable, working with an LCSW over a year with little improvement. Any suggestions? Yeah, so a couple things really come to mind when I think about this. Hold on. When I think about this patient, one is that what is it that the patient really wants to do? Like, is it do they really want to quit, or are they kind of just going through the motions? So I remember we discussed the stages of change. Let me pull that up again. So we have the stages of change with any patient and any person, quite frankly. So pre-contemplation, so this is when they don't even know that there's a problem. Contemplation, they know that there's a problem. Preparation is when they're preparing to make a change. Action is when they're taking steps to make it. Maintenance is maintaining that change. And then relapse, which is very common, is they fall off and they land somewhere in this bracket here. So, but the question is, so the person has to move along each stage, and motivational interviewing, basically the patient getting insight and motivation, is the main tool that we can use to help us move along these stages of change. So this guy, right, so it says he's tried twice, he's not been successful. So relapse it's a common thing. But my question would be, okay, so has he tried twice? Okay, like how hard has he tried? Like, did he just not do it for a couple hours, not do it for a day, not do it for a week? Like, did he throw it out versus he just put it aside? Did he stop hanging out with his other friends who use versus still spending time with them? Like, how much has he really tried? That would be my question. How much does he want to try? Like, it sounds like that he is in the either the pre-contemplation or the contemplation stage. Like, maybe he's not really trying so hard. Like, I don't know the details. As I've mentioned before, for me, I'm a huge believer in patient autonomy. So meaning that whatever the patient wants to do is, where I take that guidance from. So my suggestion to you would be, okay, focus on motivational interviewing, trying to get the patient moving along the stages of change. Assessing where they are on this stage of change can really help you, because then okay, where you have to take them along with motivational interviewing. The other thing would be this LCSW. So, how qualified are they as a clinician? Are they an addiction clinician? Because if they are just doing, for example, supportive therapy and talking about anxiety or some of these symptoms, they're not avoiding the core problem, which is the use of this the vape. So if they're not addressing the core problem, they might not be qualified to use this. You might need an addiction specialist to do this. Maybe they need to get in some sort of group program or some rehab program, some type of addiction program, rather than just pure outpatient stuff. If you want to look at medications, you could look at naltrexone. So there's nothing that really stands out for THC per se, but naltrexone has been shown to be helpful for other addictions like alcohol, and so there's some thought that it could be helpful for this as well. So you could consider naltrexone. You could consider that maybe restarting ADHD treatment, because then if you get down their impulsivity, then that may help them with the using the vape. You could also consider that, okay, what is the reason that this gentleman uses? So what does this substance do for him? Because once you know that the substance does for him, then you can see if there's other ways to alleviate that. For example, if he uses it to calm down anxiety, then what if you address anxiety in other ways? Will that reduce use? What if he uses it to fit in with his friends? If you do that, then will that help? What if he uses it to sleep? So by finding out what the underlying cause, the use is, the benefit for this patient, then you could also help them out with finding alternative routes to do that. But ultimately, it all stems from the patient's desire to want to do it. And as I've said before, that I personally believe, like, never work harder than the patient, and we shouldn't be over investing, especially if the patient is under investing, because the more it's like a tennis, right? You have a back and forth, and so you over investing is like you serving the ball, and then the person not doing anything, and then you serve again, and then they don't do anything, and then you serve again, that they don't do anything. The more you overinvest and they don't do anything, the more you condition them actually to not keep on not doing anything, because they know that you'll do all the work. Like, if someone in your house does all the dishes and the laundry and everything all the time, then it conditions you not to do it because someone else is going to take care of it. Does that make sense? Any thoughts or questions on that? Okay, so Lavita here mentioned, can we discuss glutathione and NRF2 activators, natural and synthetic? Yes. So let me pull something up here. Okay, so basically this NRF2, so this is a transcription factor. It stands for nuclear factor erythroid related factor 2. I mean, it's a mouthful, but the whole point is that basically it activates antioxidant responses. So, and one of those responses is glutathione. Glutathione is a detoxification molecule. It's involved with the redox reactions, or the reduction of oxidative species, meaning that it reduces the inflammatory and damage causing molecules. So, and this transcription factor, it stimulates other detox processes too. So now the question is, okay, how do we increase this NRF2? So it's stimulated by a bunch of things like curcumin, turmeric, resveratrol, which is grapes and berries, quercetin, which is onions and apples, alpha lipoic acid found in spinach, organ meats, sulforaphane found in broccoli, kale, cabbage. So basically a lot of these anti-inflammatory foods, they help stimulate anti-inflammatory pathways, just like we hear that berries have antioxidants in them. So this is what is happening there. So when we have N-acetylcysteine, or NAC, that we use it a lot in psychiatry for ADHD, or sorry, for OCD. Is used as a detox. Like if someone ODs, for example, it's used as a detox in the emergency room, but they'll use IV and other formulations, and that's because NAC is a precursor to glutathione. NAC and glutathione. Yeah, basically NAC becomes glutathione. So here, let me pull that up. So yeah, NAC will become glutathione, and so that's really important to know, because this is one way that we can use to help inflammation and help detox in the body. Glutathione also comes in different forms. Glutathione, so it comes in an IV form, which is not useful to us outpatient wise, but there is a form called liposomal glutathione. And this is good because the liposomal, basically if you just take oral straight glutathione, that doesn't get absorbed very well. But if you take the liposomal, it's got a capsule, so it prevents its degradation and it helps increase its absorption. So that way the glutathione can also be absorbed and help with the detox reactions. So that's one way to do it. The more studied way is the N-acetylcysteine. So that's the way that I usually go with, is just the NAC. It's cheaper. It's got more evidence behind it. And it helps our body make more glutathione for detox purposes. So does that make sense? Any questions on this? Also, there's also synthetic NRF2 activators as well, like dimethyl fumarate, sulforadics. I'm not too familiar. I've never used them personally. I've always leaned more towards the natural ways, specifically for detox activation. Yeah, any questions, thoughts on that? Okay. And then Lorraine asks, NAD plus, I'm excited about glutathione. Yeah, so NAD plus has been getting more popular lately, so I'll show you how exactly that works. NAD plus. So basically with NAD plus, right? So if you remember the stages of ATP energy production, you start with glycolysis, then you go down to Krebs cycle, and then you go down to the electron transport chain. And so, just getting into the basic biochem here, but the electron transport chain is what makes the most ATP by far. Like if you remember glycolysis and the Krebs cycle, they make like 2 ATP each, whereas the electron transport chain makes like 32 or 34. So when you have NADH, that donates electrons in the electron transport chain, and then this becomes NAD plus. And then NAD plus receives electrons in glycolysis and in the Krebs cycle, so that way it can become NADH, and then it comes to the electron transport chain to donate its electrons. So if we do NAD plus infusions, now basically we have more substrate available to receive electrons and thus to propel the electron transport chain to help with ATP production. So that can help with brain fog, fatigue, low energy depression, that type of thing. At least that's how it is marketed. How it relates to glutathione, as mentioned here. So glutathione is the detox reaction that occurs in the mitochondria. And so if we have more NAD plus, basically we have more energy, we can power up the mitochondria more, keep it running, keep it functioning better. And if the mitochondria is functioning more, think of like an engine. If the mitochondria is working more, then there's going to be more exhaust that's comes out of it, and thus you're going to need more glutathione to be able to detox that exhaust. So it's kind of like jump starting a battery. Like that's what adding in more NAD plus does. And there's also natural supplements that can help with NAD plus, specifically B3 and nicotinamide. So those are the top two that can help with that. But now I think there's a lot more infusions and stuff that are going around, and I think it's just a catchy, trendy thing. So people are doing it because it's gaining traction in the biohacking community, and providers are offering it because it's a good, easy revenue source. But I think it could be helpful for the right, especially energy low depleted patient. Yeah, any questions or thoughts on that? Okay, and then Catherine had a question here. So basically, she's got this patient, MDD, GAD, OCD, ADHD. So looks like reading the DSM criteria for bipolar. Okay. Dad diagnosed with bipolar, ADHD with comorbid. So she's on Lamictal and Trazodone. So that would be my first question, is what dosage of Lamictal and Trazodone is she on? Because that makes a difference. And how much treatment is she having? Basically, it sounds like the question here is how do you treat ADHD if they have bipolar disorder? And so generally what you want to do is you want to make sure that the bipolar mood is stabilized, and then you go about the ADHD treatment. Stimulants aren't contraindicated in bipolar. It's just something you have to be careful of. So, we want to make sure that her, so what is the dose of Lamictal and Trazodone? That would be my question. Is the Lamictal a therapeutic level? Lamictal will mainly address the bipolar depressed piece. It may not be as effective for bipolar mania or hypomania. So, it looks like there's been some irritability benefits, so you might need to assess, okay, do you want to prioritize more bipolar stability, or do you want to prioritize some of the ADHD symptoms right now? If you want to prioritize more of the bipolar stability, then you could consider adding in something like Caplyta, Vraylar, Seroquel, Abilify, something to help with the bipolar mood stabilization. Even lithium. So once you do that, especially if there has been SA here to, because lithium can help reduce the SI, so that can be helpful here as well. But then once you do that, that's when you can consider looking at ADHD treatments like Strattera or like stimulants, for example. I don't really have a preference on which stimulant to pick. Just basically, you just want to start low, and you just want to monitor to make sure that there's no mania signs that pop up. That would be the most important thing, to make sure that that does not occur. Gastric bypass symptoms and asthmatic. So maybe you might need to do an IR formulation for better absorption, or do one of the patch ones just because of that reason, just for absorption. But it's not a necessity, or an oral dissolving one. So you may want to consider something like that just because of the gastric bypass. And it looks like there's iron deficiency anemia, which could be causing some apathy, some of the tiredness, right? So it looks like the PCP is addressing there. Just follow up on that, make sure that the addressing of that is good. Like maybe she needs a little bit more than just oral iron. Is she even taking the iron? Does she need IV infusions, etc.? Yeah, any questions on this? Okay, any other questions that people had or we did not cover?
I had a quick question. So when we were talking about stimulants, I had a patient, an older patient. It was a patient who had a history of cardiac hypertension, obesity, some other things. But the cardiologist had suggested methamphetamine before using like Adderall. So the patient was on like 5 milligrams BID. And he said he had a little bit of irritability with it. Like he thought it helped with his attention, but he was kind of like, just seemed a little more irritable with it. And his sleep was affected a little bit. So I pushed the second dose back like an hour or two because of that. But question was, if we consider Strattera in a patient that, you know, say he decides to stop the stimulant, he had a history of BPH, and I know they say to like use caution with that. Is that something that you should really not use at all, or just out of curiosity, if like someone older isn't, or someone who has anxiety or can't tolerate a stimulant?
Got you. So your question is basically he tried. How old's the guy again?
He's 62.
Okay, so 62, and what was the stimulant that he tried?
Methamphetamine.
What do you know? What dose?
5 milligrams twice a day.
Okay, and
he hasn't stopped it yet. He's just a little irritable on it.
Oh, okay. What happens if he takes it once a day?
I haven't tried that yet.
Okay, and so now your question is, you're thinking of switching to Strattera because of the irritability or because of the BPH?
No, because of the irritability. My question was, if I do decide to do that, if we can't get this tweak to work, or like you said, cut back the dose, is Strattera? I've seen some things that says it's used with caution in BPH.
Oh.
So should I be really concerned about that, or is it something that maybe approach as far as like watching for those symptoms? I don't know. Just curious.
I see. Okay, so I'm not aware of Strattera and BPH interactions. The only thought that I have is that it could impact his urination.
Right.
So, for example, I remember that I had a patient on Cymbalta 90 milligrams, and he noticed, so he was on 90 and we went up to 120. And in that transition from 90 to 120, he noticed that he had more of a difficult time peeing. And so my thought was that, that could have been like an anticholinergic type of thing that was happening. So, or it could be norepinephrine related. But regardless, those Strattera, right, it's an SNRI, so I think it is possible to have that. So I think it is more likely to affect BPH, but I'm not aware of it being like a huge contraindication.
Okay. Yeah. Okay. Yeah, I just want to make sure. I saw used with caution, and I just have never had an experience in an older person with it. I usually don't use it a lot in older people, so I was just curious. Okay.
Got you. Okay. And then, yeah, I would say the irritability thing. So I would question, like, okay, is it tied to the methylphenidate, or is it related to some other things? Like, is there a correlation that's associated with the methylphenidate and the irritability.
Yeah, well, the interesting thing is he was taking a dose of steroids for poison ivy like the week before. And I was like, ooh, I told him, I said, we need to talk next week because I don't even, I don't know. The irritability to sleep, steroids could do that. The prednisone could do some things, I felt like. But.
Yeah, I mean, that's also a possibility. 5 milligrams twice a day is not that much of a dose, but you could try maybe once a day, see if that makes a difference. Or you could try 2.5 milligrams twice a day, see if that makes a difference too.
Yeah.
Yeah.
Okay.
Awesome. Yeah. And anything else? Okay. Anyone else have any other questions we didn't cover? Anything that's come up?
Aaron, I'm sorry, did you have a question regarding starting an antidepressant?
Okay.
Oh, me? I did have a question. I was just going to ask a few people when we came on. I think we were talking the last time we met about patients that are depressed and that are oversleeping. And we talked about like medications to help with that. Specifically, I thought someone had brought up certain medications that are helpful for that type of patient.
So they're sleeping in?
Sleeping way too much, like oversleeping, like constantly, and very depressed.
Got you. Okay, so a few things I would consider would be stimulating meds. So stimulating like Wellbutrin, modafinil.
That's what we were talking about. Okay. That's
Yeah,
what I was
I've had some.
Yeah.
I had this 17, 18-year-old guy, like he had trouble getting up in the morning, just trouble getting his day started,
Yeah.
low motivation, and on 200 milligrams of modafinil, he did very, very well. It just kept him going. If there's some ADHD that's component, Jornay can also be helpful because it activates in the nighttime, or sorry, it's taken at night, activates in AM, waking up 10 hours later. So it can be like that kickstart that people get to really get their day started. So that could be consideration. Yeah. If there's depression component, Prozac is stimulating.
Yeah. The patient has a seizure disorder, but we were talking about the modafinil. We were talking about that medication.
Yeah.
Yeah, modafinil.
If there's a seizure disorder, something like Lamictal could be helpful too.
Yeah. Yeah, I think he's probably already on that.
Okay. Gotcha. Yeah. Consider L-methylfolate as well.
Okay.
That could help augment things.
I remember a patient that had a history of seizures, and I had to go into the literature. If memory doesn't fail, Wellbutrin is okay for as long as you're doing XR not above 300. When you reach above 300, then the percentage only goes up, but still about 1%, not too high.
Right.
So you just have to educate. Ideally, you will start lower if you're going to go with Wellbutrin. I do have a question as a follow-up from modafinil. In this specific patient you spoke of, are you expecting him to build tolerance to it at some point in the future?
Good question. It's possible. The way that I found tolerance works is it might happen at the beginning, but then after a little bit, but then people tend to stabilize. So for example, he might stabilize at 200 or 150 or 300, and then they stay pretty good and then they can be maintained on that dose for a while. At least that is what I found, is that in titration, so you have a certain dose, they develop tolerance, and then you have another dose and develop tolerance, and then you think that, okay, if I keep increasing, they're eventually going to develop tolerance to all of it. But then at least what I found clinically is that you keep increasing, and then there's a level that you get to where the patient becomes stable on that dose, and they have that persistent benefit over it. Like they stop developing tolerance to it. It's almost like their body and them, they reach an equilibrium.
Let's move that train of thought onto the GABA receptor. So on Restoril, do you expect the patient to eventually build tolerance to it?
The sleep meds, I think people build more of a tolerance to. But even those people tend to find a stable dose for them. Like, for example, trazodone, they might build a tolerance, but then they might get to, like, let's say 150, and then they're good on that for a while. And then if they
What do
do
you define a while?
like
Is
6
it
months,
patient specific?
6 months, a year. Yeah,
Okay.
there's a poop out effect with some meds too, in which case I found that rotating med classes can be helpful. So, for example, if the restoril developed tolerance develops, then you could switch over to doxepin or trazodone or something, and then you give that category a rest.
Very cool. The FDA indicates it shouldn't be longer than 3 months, but I often wonder how they have come to that conclusion and how it's relevant to real clinical practice.
Yeah, FDA comes to conclusion based off of the clinical trials that the pharmaceutical companies provide them. And the pharmaceutical companies often do not test long term. They want to test immediate safety, and then the long term stuff is often done in the real world.
Mm.
And so, like, that's when real world data gets collected. And so that's why the FDA recommendations are, they're just recommendations, they're guidelines. They're not, this is set in stone.
Mm. Okay, thank you.
Yeah.
Thank you.
Yeah, of course. Anything else? Any other questions we didn't cover?
The Krebs cycle, can we go through that once again?
That I will leave you to yourself. That sounds like PTSD trauma coming back.
Yeah.
Yeah, but basically the main thing to recognize, in regards with their conversation with the Krebs cycle here, let me pull it up, right? So you see how this is where the NAD plus gets used. So the NAD plus comes NADH, NAD plus NADH, NAD plus NADH, and then this NADH gets funneled to be used in the electron transport chain.
Mm.
Yeah, so that's the main thing that, at least for our conversation today, that we should know.
That's funny because we all everybody in class convinced ourselves that we were never going to touch a Krebs cycle again, but here we are.
Here we are. Yeah, I mean, like, there's a reason that we learned it. It helps us then to understand the fundamentals. Yeah. And anything else we didn't talk about or cover?
I do have a quick question.
Yeah.
About a patient. So I have a patient, 63-year-old male, history of schizophrenia. He's currently on about 800 milligrams of Seroquel. He was recently Baker acted, brought him, now this is a SNF facility, brought him back. They added 100 milligrams of Thorazine 3 times a day. He's also on Premarin for increased sexual behaviors. We had tried the Prozac, we had tried Paxil, that didn't work. And then we finally did a Depo-Provera injection. Have you had any cases with that at all?
No, I haven't.
To use that? Okay.
I've never, no. So, and because I was just looking that up too, so it looks like Premarin, so it's a conjugated estrogen tablet.
Mm-hmm.
Interesting. Okay, so you gave him estrogen pretty much to reduce his hypersexuality.
Mm-hmm. And it worked. It did work for some time. But then he ended up getting Baker acted, and then, like I said, they added the Thorazine. It came back, and then he was still having these sexual behaviors. And spoke with my psychiatrist, and said we could try this.
That's so interesting.
I didn't know if you had any experience with that.
No, I haven't. What about SSRIs? That's the main one I've had to reduce sexual.
Yeah, we already tried Paxil, maxed out dose. He's on Prozac right now, 60. So it was like nothing was touching it. And like I said, the Premarin was working for some time, months, like 6 months. But as soon as he became unstable, what happened was, I guess he smoked some marijuana from another resident, and he became psychotic again and unstable. So it's like almost like we're back to square one with this patient. So.
I see. So you think it was the THC that did that?
I don't know. It seemed to almost destabilize him when he did smoke it. So,
Like, I wonder if it's like a bipolar type of thing where he's becoming hypomanic or manic, and that's causing the
well,
impulsivity.
he was very delusional and having audio hallucinations, very psychotic symptoms. Called 911 saying that there was an active shooter in the building.
Yeah,
So,
got you. Yeah, so because he has the diagnosis of schizophrenia, so
yes.
like it could be like a schizoaffective. There's some bipolarity component to
Yeah,
it.
he probably does. I mean, he is on Depakote. We have him on about 1,500 a day, rough about. And his VPA level is like 70s to 80s, so it's been pretty normal.
Okay, got you. And so,
So
is there a trigger that you established for the the behaviors, or like a correlation?
that's what we're thinking, that may have been the THC.
Yeah.
So, but it's almost like it is really hard to restabilize him when he smoked this marijuana. So, and also too, it seemed like when he went on the Seroquel and came back with the Thorazine, like it was a lot, 100 milligrams 3 times a day. Is that something that you have seen, like that much started at once, or?
I haven't seen it all started at once, but I could see it. Like if
Okay.
he's already on 800, it sounds like
Yeah,
that,
Seroquel. Mm-hmm.
he's
Yeah.
probably treatment resistant, and so now you want another sedating one, because Seroquel is already pretty sedating, and so now
Yeah.
adding in Thorazine. So I would just be also mindful. I mean, this guy's 63, so he's approaching elderly. Plus he's schizophrenic, so his brain is already deteriorated past the average 63-year-old brain. So
Right.
this too much sedation could be really sunken amount.
Yeah.
Yeah.
He seems pretty. He's alert. He hasn't. When he came back, he didn't have any type of like confusion or sedation, but just more of the increased sexual behaviors when he came back.
So maybe it could be an anticholinergic thing that's happening too. Yeah, so because I remember there's a case I shared. I had the basically 65-year-old guy. He was on amitriptyline for 20 years. He was having visual hallucinations, and then we took him off the amitriptyline, and the visual hallucinations went away. So, but if because Seroquel has some anticholinergic activity, it's the sedating plus adding in Thorazine, which has it. It could be that there's too much anticholinergism going on, and that's causing the disinhibited behavior in this dementia approaching patient.
Okay.
Just a consideration.
Yeah. We were thinking that, we were thinking if he still has these psychotic symptoms, we might just try to transition over to clozapine. So.
Yeah, I mean that could be the move too. Just be mindful of the anticholinergism also with clozapine.
Exactly. Okay.
Yeah.
Interesting. All right. I appreciate it.
Of course, yeah. Anything else?
All right.
Anyone else or any other questions anyone has? Okay, awesome. So I'm glad that has been helpful. Only one more thing I wanted to share with y'all. So I added in a new lecture. Basically, so this module, so I switched it over to holistic psychiatry instead of just supplements. And then if we look over here, so I added a couple more lectures on nutrition. So here I need to put in the video, but added one on the different diets that are used in psychiatry, like Mediterranean diet, keto diet, like anti-inflammatory diet, etc., etc. So added that in, as well as a thing on intermittent fasting, basically explaining intermittent fasting, what it is, how it works, etc. And then in this nutrition one, this one is on like energy balance, how weight loss works, how calories work, proteins, carbohydrates, fats, etc. Just because I think it's important for us to be at least aware of nutrition. That way, patients ask us questions about weight loss and other things, we actually have some level of opinion we can give them. Because I know, at least for me, like I didn't receive much nutrition training, and so I had to learn a lot of this on my own. So I wanted to provide that too.
Great, thanks.
Yeah.
Hey, I have no question, but I'm new here, I'm a new NP looking for a job, really. So that's been frustrating in the Arizona area. Just FYI, but I decided to sign up for this class, to get this kind of information and mentoring. So I don't know how long everyone has been in this profession, but it's kind of stressful, when you're new. And I've done many interviews, but some of them are like, okay, we're going to get back to you. We're going to get started in a few months, and then they really don't come through. So any tips will be appreciated.
Yeah, so you could definitely post about job interview tips or like, finding a new job and stuff in the community tab. And so I think, that way people can give their opinions. So you can see if anyone else is in the Arizona area as well. Okay, let me just share my screen. So if you go to the map here, you can see where different people are. Right?
Okay.
And so all over the United States, so it looks like Arizona, we got a couple
Phoenix,
people
yeah.
here,
Mhm.
right? So it looks like Jen is there, Carrie's there as well, so they might be helpful in that area. And then in Vegas, we looks like Dawn's there in Vegas. So
Oh.
yeah, so this can be helpful just to see where everyone's at. And then definitely you can post, if you post in the community, there's a section um, on career opportunities. So you can post there and ask about that. And then people might have stuff that that comes up. Yeah, I can reach out on my network as well too. And then the only other thing I wanted to mention is that so we'll have our process group call. So that's where we talk a lot about. So right here at 8 p.m. And so this is where we kind of just bitch and complain, for lack of a better word.
Okay.
Yeah, but it's
Sundays?
yeah, it's all unrecorded, and but essentially it's a way for us to process things that are difficult in the field and just be in a safer community environment where all of us get it.
Oh, that's perfect. And so I have access to this community for how long? Like, I mean, like.
Absolutely. So any kind of like those kind of questions, you can just ask me privately, but this is more for the clinical questions. So yeah, happy to answer that. And any other clinical questions that we didn't cover?
So, but my membership here is valid for how long, or there's no end time expiry?
Yes, so it's pretty much just however long you want to stay.
Okay, thank you.
Yeah, absolutely. So yeah, awesome. I'm glad that this has been helpful. Otherwise, yeah, I will see you guys next week, or actually on Sunday, Sunday night.
Good night.
Okay, thank you.
Thank you.
Awesome. Good night, guys.
Thank you.
Okay, so that was how do we join your mentorship? Yeah, so that was a community call that we just had. So basically the best way to join is to you can check it out in my bio, or you can just send me a message here and you can join that way. So yeah, either way, just send me a message and then you can join. But otherwise, yeah, I hope this has been helpful. That was our coaching call, and I'll probably do another live in a bit. But otherwise, I will see you soon.